43. Barium edema. 10 minutes later, patient collapsed. She is drowsy. What is the most likely complication to have occurred, cause of acute illness? Water intoxication. Because when she is drowsy, so it means it is due to water intoxication. Drowsy after barium edema shows water intoxication. 44. Palpable mass in the right lower quadrant. CT shows Doppler and hypertonating mass with thick walls, septae, and carbonaric calcification. In the right iliac fossa and displaces and distorts the adjacent psoas muscle, most likely diagnosed with maxilloma peritoniae. Again, there is mass in the right lower quadrant, and then there is carbonaric calcifications, and in the RF and displaces adjacent psoas muscle, most likely diagnosed with maxilloma peritoniae. Maxilloma retroperitoneum. Remember this because it displaces the adjacent psoas muscle. The psoas muscle is in the retroperitoneum, with maxilloma retroperitoneum. 45. CT scan shows peripancreatic fat stranding and a severe laceration in the tail of the pancreas, which extends to less than 50% of the pancreatic thickness. Next most appropriate step, supportive therapy. Because there's in pancreatic injury grading, duct injury is important. If there is no duct injury, then supportive therapy. 46. Failure to thrive. Long history of respiratory disease. CT shows lower attenuation, minus 90 to minus 120 HU in the region of the pancreas and air trapping and cystic bronchitis in upper lobes of both lungs. Most likely underlying pathological causes, hypermatus pursued hypertrophy of the pancreas. Correct? Again, patient has failed to thrive. Long history of respiratory disease, so diagnosis is cystic fibrosis. Then CT shows lower attenuation, minus 9 to minus 120 HU in the region of pancreas and air trapping and cystic bronchitis in upper lobes of both lungs. With this minus 90 to minus 120 HU in the region of pancreas shows fatty channel pancreas. And then, what is most likely underlying pathological causes? Leprematis, pseudohypertrophy of the pancreas. Correct? It is seen in cystic fibrosis. For example, series of ill-defined rounded areas at the root of the mesentery with adjacent mild lymphadenopathy. There is some central calcification. A rim of preserved fat is seen surrounding the adjacent vessel, which is diagnosed sclerosing mesenteritis. Again, there are series of ill-defined areas in the root of the mesentery. So it's mesenteritis, and then some central calcification to diagnose sclerosing mesenteritis. No other option make any sense. 48. Which finding in the pancreatic head is most in keeping with the diagnosis of pancreatic adenocarcinoma? Hyperintensity during arterial phase enhancement. Pancreatic adenocarcinoma is hypervascular on CT and MRI, so it shows hyperintensity during arterial phase enhancement. 49. CT shows excessive soft tissue thickening between the head of pancreas and duodenum. Small cystic lesions are not seen along the medial wall of the duodenum. Mild irritation of the common bile duct and distension of the stomach and proximal to duodenum. Most likely diagnosis, groove pancreatitis. What is groove pancreatitis? Inflammation of the pancreatico duodenum groove is groove pancreatitis. So here they are saying again, it's soft tissue thickening between the head of pancreas and duodenum. So the pancreatico groove involved. Soft tissue thickening between the head of pancreas and duodenum, then small cystic lesions are seen along the medial wall of duodenum, mild irritation of common bile duct and distension of the stomach to diagnose groove pancreatitis. 50. CT shows pericolic pancreatic mass with fat attenuation and hypertonating peripheral rim with adjacent fat stranding, apering the anterior sigmoid colon, most likely diagnosed epileptic appendicitis. CT scan shows pericolic pancreatic mass with fat attenuation and peripheral rim, hypertonating peripheral rim with adjacent fat stranding, apering the anterior sigmoid colon, most likely diagnosed epileptic appendicitis. 81. CT shows tortuous and prominent intrahepatic and extrahepatic arterial branches with early filling of dilated hepatic veins and inferior cava. Mosaic perfusion with multiple enhancing foci. Portal venous phase shows homogeneous enhancement of the liver with prominent hepatic veins and inferior cava noted, which is diagnosed Osper-Weber-Rendu syndrome. Other name of Osper-Weber-Rendu syndrome is hereditary hemorrhagic telangiectasia. So you can see it shows tortuous and prominent intrahepatic and extrahepatic arterial branches. So this is telangiectasia. From this, we can understand the diagnosis is HHT or Osper-Weber-Rendu. Then tortuous intrahepatic and extrahepatic arterial branches with early filling of dilated hepatic veins and inferior cava mosaic perfusion. Then, so this is C answer. 32. Colon cancer. It shows irregularity of the outer wall at the site of the tumor. A cluster of 3 lymph nodes with the largest inferior node measuring 0.9 mm and no distal metastasis, most likely TNM staining, T3 and 1 M0. Cluster of 3 lymph nodes, 3 local lymph nodes and 1 T3 is irregularity bowel wall outside of tumor. So diagnosis 53 and 1 M0. 53. Background arthralgia, small bowel series shows prolonged transit time and dilated loops of small bowel with normal appearing valvulae and posterior diverticula was diagnosed GI scleroderma. No other option make any sense. So the patient has arthralgia and then small prolonged transit time, small bowel dilated loops of small bowel, normal valvulae and posterior diverticula was diagnosed GI scleroderma. These all make no sense. 34. Series was cluster of non-encapsulated dilated small bowel loops adjacent to the anterior abdominal wall on the right side. Adjacent covered masonic vessel, diagnosed transmasendric hernia. Series was cluster of non-encapsulated dilated small bowel loops. Cluster of small bowel loops adjacent to the anterior abdominal wall on the right. And then there's called masonic vessels which are off the small bowel loops, so diagnosed transmasendric hernia. 35. Series was large bowel dilated with diffuse bowel wall thickening. Some of the oil contrast given has become trapped between the dermatocortical folds, causing alternating bands of high and low attenuation, or diagnosed pseudomembranous colitis. This is also called accordion sign. Small bowel dilatation, thickening, then contrast trapped between the dermatocortical folds, causing alternating bands of high and low attenuation. This is accordion sign. Accordion sign. 56. No perforation due to chicken patient. Prime study shows no perforation due to chicken or fish bones. Prime study shows modulated long stricture in the lower esophagus with multiple distinct ring-like indentation, most likely diagnosis idiopathic eosinophilic esophagitis. Correct? There is no perforation due to chicken or fish bones. So this is important. In patient who has a history of chicken to fish bone infection, is most likely he has seen a condition called eosinophilic esophagitis. And then it also shows long stricture in the lower esophagus with multiple distinct ring-like indentations. Diagnosed idiopathic eosinophilic esophagitis. Okay. 57. Gallbladder shows reverberating artifact that gives common tail appearance. What is the true recurrence condition? Erythematosis is associated with cholesterolosis in up to 1/3 of patients. Erythematosis is associated with cholesterolosis in up to 1/3 of patients. 58. History of AIDS. CT shows ascites with peritoneal thickening, several years of mural thickening and small bowel and multiple lower lymph nodes, which infection is most likely TB. In AIDS patient, there is ascites and then there is multiple lower lymph nodes, so diagnosed TB. 59. History of malabsorption. Series of dilated fluid-filled small bowel loops and multiple enlarged masonic lymph nodes encased in the masonic vessel. Lymph nodes show soft tissue density, most likely cause of this finding. Celiac disease complicated by lymphoma. Again, history of malabsorption, so celiac disease, then these are fluid-filled small bowel loops, multiple enlarged masonic lymph nodes encased in the masonic vessel. Lymph nodes show soft tissue density, so celiac disease complicated by lymphoma. Then 60 glucagon in barium anemia, which is correct. Insulinoma is a contraindication to use of glucagon. Insulinoma is contraindicated to glucagon. 61. Series focal intraluminal abnormality with appearance of mass within the sigmoid colon. Concentric rings of soft tissue and fatty attenuation give a target-like appearance in the sigmoid colon. Masonic vessel course into the lesion. Large bowel distal to the sigmoid colon is collapsed and the proximal to the lesion is just dilated colon, where most likely underlying pathology, benign tumor. Is interception due to lymphoma. Okay, let's read it. CT shows focal intraluminal abnormality with appearance of mass within the sigmoid colon. There is mass in the sigmoid colon. Then there is concentric rings of soft tissue and fatty attenuation. Rings of soft tissue and fatty attenuation giving target appearance. So they are fatty tissue, correct? Fatty tissue giving target appearance. Then masonic vessels core into the lesion and large bowel distal to the sigmoid lesion is collapsed. Proximal so target appearance, and then there's fatty appearance. So this is most likely interception due to lipoma, and it is benign tumor. Lipoma is a benign tumor. So to known history of malignancy, solitary hypertension lesion in the spleen measuring 4 cm in diameter. PET CT is not helpful. With malignancy, the patient is most likely to have renal cell carcinoma. Because renal cell carcinoma is not FDG avid, does not show FDG uptake. The patient has lesion in the spleen Known history of malignancy, lesion in the spleen, port injury, and PET CT not helpful. So renal cell carcinoma. 63. Incidental 6 cm well-defined cyst in the spleen, most likely the etiology of the spleen cyst post previous trauma. Traumatic spleen cyst. 464. Number of 8 mm filling defect in the CBD. Which MI sequence is likely to be the most helpful in trying to determine if the filling defect are due to pneumobilia as opposed to retained calculi? Exactly 2 state gradient echo. So 8 mm filling defect in the CBD, and then which MI sequence to determine if this is due to pneumobilia? Actual T2 steady state GE. Axial T2 gradient echo MRI. 65. One audience asked if any of the contrast agent used MRI of the liver works best with any sequence other than T1W sequence. What do you respond? Yes, SVIO. SVIO contrast agents work best with any sequence other than T1WI. 66. CD shows large exophytic mass arising from the jejunum in the left upper quadrant, heterogeneous intensity, and has some peripheral enhancement and general necrosis. No calcification, most likely diagnosis, gastrointestinal tumor. A large mass arising from the jejunum in the left upper quadrant, heterogeneous density, and has some peripheral enhancement and central necrosis. Central necrosis, no calcification, most likely diagnosis, gastrointestinal stromal tumor. 7. Dysphagia. Patient barium solid shows barium-filled sac extending posterior inferior from the C5-6 level to the left of the upper esophagus, most likely diagnosis, Jenker diverticum. Dysphagia history. Barium solid shows barium-filled sac extending posterior inferior from the C5-6 level, so diagnosis of the esophagus, diagnosis, Jenker diverticum. 68. History of panproctocolectomy for Gardner syndrome, desmoid tumor. Brain abdomen is desmoid tumor, most likely to be located. Small bowel mesentery. For desmoid tumor is associated with family FAP and Gardner syndrome, correct? So, where is desmoid tumor most likely to be located? In small bowel mesentery. Question number 69. CT coronography. Which segment of the corona is likely to be better distended on bone scan? Rectal squamite. On bone scan, better distended is rectal squamite region. Question number 70. Liver transplant recipients undergo Doppler ultrasound assessment at 1 year for DNA liver function test. Color Doppler imaging shows stenosis in the hepatic artery and that is presumed as transposis. This statement in regard to pulse Doppler finding is false. This is index of 0.59 digital to stenosis. The patient, liver transplant patient, undergoes Doppler ultrasound assessment at 1 year due to DNA liver function test. Color Doppler shows stenosis in the hepatic artery. So, if there is stenosis in pulmonary artery in the hepatic artery, then the residual index will be less than more than 0.9 because there is stenosis. 71. Radiofrequency ablation is uncommon in the immediate post-ablation period. Mural nodule in the cyst pattern. After radiofrequency ablation, uncommon in the immediate post-ablation period is mural nodule in the cyst pattern is uncommon. 72. History of abdominal bloating and cramps. Small bowel series shows some dilatation of the bottom of small bowel, the segmentation flocculation of the brim, and increased number of normal thickness. Folds in the ileum, no structure formation, most likely diagnosed, celiac disease. Segmentation flocculation of the brim is seen in celiac disease. And history of malabsorption, abdominal bloating. 73. Crohn's disease, MR enterography, which MRI finds earliest inactive inflammation, mucosal hyperenhancement. In Crohn's disease, MR findings in early active inflammation is mucosal hyperenhancement, resistant inflammation. 74. History of medulloblastoma, innumerable colonic polyps on colonoscopy, most likely diagnosed Turgot syndrome. Medulloblastoma plus colonic polyps is Turgot syndrome. 75. Hepatobiliary scintigraphy using G13 and MTC labeled immunolytic acid range, which findings are consistent with acute cholecystitis, non-realization of the gallbladder at 1 and 4 hours. Those cholecystitis. In hepatobiliary scintigraphy, cholecystitis shows non-realization of the gallbladder at 1 and 4 hours. Okay, stop.